So, caught between a rock and a hard place, examining the risks and benefits from benzodiazepines, and may I urge you to do it with the most open mind that you have. Let's look at the benzodiazepine landscape in the United States, because what we are seeing growing dramatically is the use of benzodiazepines of at least the kind that we're used to. So things like alprazolam, things like clonazepam, lorazepam, but also zolpidem, which is not called a benzodiazepine but does work on the GABA A receptor. So, of the top 10 most prescribed drugs recently, 4 of them were in the general class of benzodiazepines. So, is this too much? Is this just right? Is this not enough? Well, we're going to have to examine that together. This is a more recent study from Dr. Agarwal and colleagues, and what they are also finding is that there is a dramatic grow tendency of benzodiazepine use in the USA. And psychiatry is not showing any signs of decline. The question, though, is that a good thing or is that a bad thing? At the moment, we don't know. And you are going to have to struggle with it to figure out in the right patient what exactly to do. And on top of that, what we're finding out is the misuse of benzodiazepines is also on the rise. So we have 2 challenges. We have not only use going up, but on top of that, it's becoming quite evident that misuse numbers are also happening. And most of the misuse in America is not happening because people are importing drugs from Mexico or overseas. It's almost always happening because of our prescribing habits. They either get it from their friends or some other mechanism. So it's a complicated issue. But as I went to my original topic, yeah, there's a lot of use of benzodiazepines, but so what? There's a lot of use of broccoli in America. Does that mean we have a broccoli addiction? I guess all I'm doing is challenging our thinking to not automatically assume because the use is greater and because some people do misuse benzodiazepines, does that automatically mean that psychiatry or medicine should stop prescribing benzodiazepines? Does it mean that? Or does it mean we're mostly doing the right thing and some people are getting caught in the benzodiazepine challenge? You decide in a few minutes when I show you the data. The VA, which is of course one of the largest providers of psychiatric and mental health care services in America, clearly do think there's a benzodiazepine problem. They are generally speaking trying to decrease it. They are fine with using it acutely, subacutely, but they do believe that long-term use of benzodiazepines, which in their definition is 2 weeks or longer, sometimes they call it 4 to 6 weeks, is generally speaking a potential challenge. And please note, I use the word potential. It's not a definite challenge. There are some patients who are best served by using benzodiazepines long term. But the VA's position is, but the only way to find that out is after 4 to 6 weeks of therapy, you have an exit plan of slow tapering off with psychoeducation and then see if the patient still needs it. It's a pretty good plan. Majority of benzos, vast majority of benzos in America are not illicit. They're not illegal. They're coming for your and my prescriptions. There are challenges. There are genuine challenges, particularly in the elderly patients. And in the elderly patients, the risk of hip fractures is actually fairly strongly associated with use of benzodiazepines. The challenge is this is cross-sectional data. So we don't quite know if this is association or co-relationship. It probably is association because benzodiazepines do obviously change balance and gait, and the elderly patients are much more likely to have those challenges. Please look at the blue box at the bottom. The risk is actually quite substantial. So watch out for benzo misuse in everybody, but the elderly folks, it may be a particular problem, and driving. So sleep drugs are often thought to magically disappear the moment you wake up in the morning. They're supposed to just go away, right? But not always. In fact, with the Z drugs, particularly zolpidem, which is the most widely used Z drug in America, it can be quite challenging, particularly in the morning. And you'll find this so interesting. Impairment can last up to 11 hours after dosing. 11 hours. And the magnitude it can be compared to is a blood alcohol level concentration of 0.8. So I think these are very valuable drugs. We should not immediately say, okay, let's stop using it. But it may be very important to educate patients. And the data that I just shared with you wasn't zolpidem data, was zopiclone data. But it may be very important to share with patients that their morning driving may be impaired. They probably don't want to wait too late to take it, and they need to use the minimum possible dose. This is not to create a sense of terror in the minds of clinicians or patients, but to create a sense of these are powerful drugs, and sometimes they have challenges that we're not fully aware of. Here's something else that was very worrisome. Without a doubt, opioids increase the risk of hazard, mortality, just the use itself. But benzodiazepines aren't all that far behind. And it doesn't appear to be a psychiatry issue. It appears to be a drug issue. As you can see on the right-hand side, opioids, antipsychotics, and benzodiazepines, but not antidepressants, were associated with this risk. Just in case we start worrying this is only an American problem, this is a German study that shows us, no, this is a challenge all over the place. This is not just an American problem. It is an American problem, but it is also a overall worldwide problem. And I do want to remind you that psychiatry, generally speaking, does not prescribe opioids, but our patients have other clinicians, and they may be receiving opioids for other reasons, legitimate reasons. The patient may not even be trying to doctor shop, but if they do receive a opioid and they receive a benzodiazepine, there is greater concern about accidental overdosing or intentional overdosing, and that leading to fatality. So benzodiazepines by themselves do not appear to be a huge risk for death and overdose, but once an opioid steps in, it dramatically gets augmented. So here I'm showing you more data. And I'm showing you more data because my goal was not to spoon feed anybody, but to just show you the data so that you can make up your own mind. And I'm very much hoping at the end of all of this, your mind won't be made up in one direction or the other, but it'll be made up in the direction of caution, but not avoidance. But we will see during Q&A what you thought. So, yeah, more database that's coming out that is showing that benzodiazepines in particular, when combined with other molecules, particularly opioids and alcohol, can lead to poor outcome. And there is actually, in fact, it's going down a little bit, but in fact, there is a significant cultural trend for glorification of benzodiazepines. There's actually a California rapper who has tattooed on his face his love for Xanax and named himself Lil Xan. This is not a joke. It really is true. And his group is called Ex-Narky because they like benzodiazepines so much. But I do have some good news. This gentleman has had many, many troubles with benzodiazepines, and now he has changed completely into being so wildly pro-benzos, and everybody should use the bars and X's, as Xanax is often called on the streets, to actually saying something quite different. He's saying, I got into a lot of trouble, and asking his fans not to do the same thing. But here's the challenge in thinking of the benzodiazepine situation as, oh my God, it's all bad. It's like meth. It's all bad. In other words, anybody who uses benzos or prescribes a benzo is just evil. The problem for you and I, and it's a good problem, is that benzos are in fact very effective medications for multiple conditions, in particular for anxiety disorders. So look, GAD for example. SSRIs, effect size 0.32. SNRIs, effect size 0.35. Benzodiazepines, effect size, generally speaking, 0.49. And the difference between 0.35 and 0.49 is pretty massive. Cannot walk away from benzos. I guess you could. No one can force you to prescribe benzos, even in the right situation. But the question is that a thoughtful approach? Is that the right thing by the patient? Is that the right thing in terms of our obligation as healers and as people who wish to reduce the suffering of our patients? So the conundrum is, we're caught between a rock and a hard place, aren't we? It's not as simple as all bad or all good. It's complicated. So how do I learn to divide and conquer? So let's go into history. So from 35 years ago, this actually is more than 35 years at this point, it's closer to 40 years ago, there was an over-enthusiasm about benzodiazepines. Over-enthusiasm. It was like, oh yeah, put it in the water. It's so good for patients. Start them on it, leave them on it. They like it, they're better. What's the problem? And then, of course, about 2 decades ago, we started running into problems. This is the contemporary view of benzodiazepines. And the contemporary view is, yeah, we do help a lot of people, but we actually also harm not a small number of patients. So what do? Is there a wise way to pick the patient? Is there a wise way to exclude a patient? Is there a wise way to prescribe short-term, then come off it? And then the final question is, are there some patients where staying on chronic benzodiazepine therapy is in fact the right thing to do medically, morally, and ethically? That's where we are, thank God, finally, with benzodiazepines. We are no longer automatically painting them with a all good or all bad brush. We are being far more thoughtful about it. So the pendulum in psychiatry always swings. It doesn't matter what drug it is. It doesn't even matter what kind of psychotherapy it is. For a while, psychodynamic psychotherapy was the only kind of psychotherapy. And then 20 years later, it is evil and nasty. Look, it does nothing good for people. And then after a while, it falls into place. The pendulum comes to the right place. We are not there yet with benzodiazepines. Many of us, without being very thoughtful, pick one side or the other. We either become very protective of use of benzodiazepines or we become anti-benzodiazepines. We make patients feel better. We feel bad that they had to use a benzodiazepine. We force the patients to come off it. We cut their doses down without any thought. That's the pendulum swinging in the wrong direction. But then there are some of us who think they're so wonderful, everybody should have it. And if it works, then you leave them on it. That also is incorrect. Both sides of the pendulum swings are very damaging. And of all the drugs in psychiatry at the moment, the one that appears to be the least decided by the specialty appears to be benzodiazepines. So look at the illustration on the left-hand side. Here I'm showing you a clinician who actually quite wisely is balancing both issues. And it's not all that difficult. It actually isn't. It sounds like it's going to be hocus pocus, dramatically difficult for us to figure out. It's not. Remember 3 goals. There are no absolutes. That actually gives me freedom. In other words, I don't have to be a fortune teller and automatically know when I see a patient automatically they don't need it, they need it, they need it for a short term, they need it for a long term. I don't have to decide that right off the bat because there are no absolutes. Benzodiazepines, point number 2, can be both very useful in some patients and could be a major challenge in some other patients. Point number 3, our goal is to be fair, balanced, wise, and careful. And the rest of the conversation I have with you, we're going to try and increase our wisdom, our knowledge. How do we serve patients and how do we do our very best